Thank you very much for the kind introduction. I have no disclosures. So first, something about sentinel node navigation surgery in early gastric cancer. This is still regarded as an experimental treatment in most of the guidelines. However, there are some general principles that we can adhere to. It should only be performed for clinically T1 and 0 patients. Usually, a dual tracer is injected submucosally in the 4 quadrants around the primary tumor, and a sentinel lymphatic basin dissection is performed. So not just the sentinel nodes, the hot and green nodes are resected, but also this basin where they belong to, and this is divided along the 5 main arteries of the stomach. If during frozen section the sentinel node is negative, function-preserving gastrectomy can be performed or an endoscopic resection. If it is positive, a laparoscopic formal gastrectomy should be performed. The big advantage of these functional preserving procedures, as we have seen in the previous talks, of course, a better quality of life for the patient with an equal oncologic outcome. In the Netherlands, we have limited experience with this because it's early gastric cancer is a very rare disease, but there's a very good clinical trial performed in Korea. This is a multi-center study that randomized between sentinel node navigation surgery and a formal D1 plus lymphadenectomy and gastrectomy for patients with an early gastric adenocarcinoma, and the endpoint was survival. They used a dual tracer, and during surgery there was a frozen section performed, and if this was positive, then a formal gastrectomy and lymphadenectomy was performed, and if negative, this could be done with function-preserving procedures such as one of these. The short-term results showed they randomized 580 patients, almost 600, with a very high rate of detection of the sentinel node, and a median of 8 resected sentinel nodes with a median of 0 positive sentinel nodes. And there were 35 intraoperative failures, and these are listed here on the right side, but this also included, for example, if a sentinel node contained a lymph node metastasis. And postoperative failure were 12. There was no morbidity or mortality in that group. And very recently in Annals of Surgery, the long-term results are published, and there was no difference in survival. However, in the per-protocol analysis, there was a significant lower survival, disease-free survival in the sentinel node group, but this was due to that there were more gastric cancer-related events in this group, and that concerned metachronous cancer or a recurrence at the primary cancer site. And the authors recommend that sentinel node navigation surgery can be recommended as an alternative, considering the better quality of life in these patients, but that the stomach itself should be closely surveilled in follow-up. And these are the survival curves. You see that the survival in both groups is really high, although there was a difference. And which is also very important to acknowledge is that in the sentinel node group, there was only 1 patient with a recurrence in a regional lymph node and 2 in distant lymph nodes. So the sentinel nodes are very accurately detected. Then in early esophageal cancer, we have experience with this in adenocarcinoma, which is the most frequent histology in the West. So this was our research question. So if patients have a high risk T1B esophageal adenocarcinoma, these are currently treated with esophagectomy because of the risk of lymph node metastasis, which varies between 0 and 37%. However, if a radical endoscopic resection is performed, can you only do a lymphadenectomy? So we did this in human cadavers first, and we found that after the lymphadenectomy, there was only 1 lymph node retained on the esophagectomy specimen. And then the next phase was that we operated 5 swine, and then we also did only the lymphadenectomy, so a complete lymphadenectomy. And we let the swine survive for 28 days, and then we investigated the esophagus, and there were no signs of stenosis or ischemia. So we concluded it was feasible, and then we did this in 5 patients. So we did first a complete lymphadenectomy in the abdomen and in the chest, and then second, the esophagectomy in the same procedure. And we found that there was a low rate of retained lymph nodes of 6. However, we observed a discoloration of the esophagus during the procedure because it was impossible to do a radical lymphadenectomy without transecting 2 little vessels. So then we switched to the sentinel node concept. And we first did this in 5 patients where we used only technetium, and then we did the sentinel node, and then followed by the esophagectomy. And there was a good high concordance between the imaging preoperatively and the probe-based detection. However, it was difficult to detect the lymph nodes close to the primary tumor because of the scattering of the technetium. So in the next phase, we added ICG. And then we were able to identify in 2 patients additional peritumoral sentinel nodes. None of these patients had micrometastasis. So in the next phase, we just did the sentinel node procedure and without the esophagectomy, so in 10 patients. So the primary tumor was radically resected. We did the injection of the hybrid tracer and a SPECT scan, and then the next day we did a thoracoscopy and a laparoscopy in all these patients to detect sentinel nodes with the probe and fluorescence. And we were able to localize and detect all the sentinel nodes, and also in 20% of these patients, the sentinel node was positive. So we were able also to detect lymph nodes with metastasis in it. And there was a high concordance also between the imaging and the intraoperative detection. And there were no functional disorders. And also until now, these patients refused esophagectomy after resection of the sentinel node. And until now, they don't have a recurrence. So there are very few events. So we think maybe the sentinel node procedure is not advised for all patients. So we'll try in our next studies to identify high-risk patient group, which is still quite challenging, but maybe also the patient preference can play a role in this. And maybe it can also be as a therapeutic option if a patient develop in endoscopic ultrasound, for example, a lymph node metastasis, that you can then do the sentinel node, and I try to identify other sentinel nodes as well. But this is, of course, very experimental still. And this is what it can look like during the operation. So the sentinel node here along the arch of the atricos vein. And here you see the primary tumor site and the lymph node behind it. So this was with only technetium would be very difficult to detect. But with the hybrid tracer, we were able to detect this lymph node and resect it. You see how very nice green this is. So this was a hot and a green lymph node. And also in the abdominal phase, this lymph node was a little bit behind the left gastric artery. You can see it here. And also here, this was a hot and green lymph node, which we could resect for to investigate it. Then ICG-guided lymphadenectomy and advanced gastric cancer. Of course, in these cases, you do a D2 lymphadenectomy. This is a randomized controlled trial that investigated this in 266 patients. And they found more lymph nodes resected, both perigastric and extraperigastric, and also within D2. And there was less non-compliance to D2. There were, however, not more positive lymph nodes resected, however, and the morbidity was comparable. And this is just very recently published, and they found really an increased survival in the ICG group, which is really quite remarkable, I think, because the difference is really marked. This I skip. In Europe, we don't have a study on this yet, but this is an Italian trial, and we also participate in this. And this we'll have to await the results in a couple of years. This is a video from my friend Hung, who's here also in the audience. His last talk today is moved to the session tomorrow morning at, I think, 8 o'clock. So we can all go there tomorrow. You see how nicely this in the laparoscopic gastrectomy, you can see the ICG fluorescent lymph nodes. And here you can see that it can be really beneficial to add this green contrast. And also in robotic cases, this can be applied. Also a video from Professor Hung. He did it with the Firefly system. So you have to switch between the two different modes, but you can also see how nice visible these lymph nodes are here in the splenic hilum. And this can really guide your lymphadenectomy. Then in advanced esophageal cancer, there's a few studies on this, not really big series yet. And this is almost 90 patients, and 98% of the lymph nodes were ICG positive, and of the lymph node metastasis, of 3.3% had ICG positive nodes were lymph node metastasis, and no metastatic nodes were ICG negative. And this study from Japan in 53 patients also investigated this, and they found that the sensitivity and specificity were not that high, but this was also especially so in the patients who had chemotherapy. So if you had a patient without chemotherapy, the sensitivity and specificity increased. So we also do this, and we just started with this study, and I have a short video, and we're still a little bit looking for the optimal dose and the injection time. We now injected, first we inject some saline, and then to create like a bleb, and then inject the ICG in 4 quadrants around the esophagus. And then we do the esophagectomy right away. And then of course first the abdominal phase, and then in an Ivor Lewis, and then the chest in the same procedure. And here you see also that it's quite feasible, but we don't have any results on this yet. But it feels good that you have some visual control, and we also have a short video of the chest. And you see the superior caval vein and the tracheal border here. Here you see the recurrent laryngeal nerve, the vagal nerve, and there's a lymph node behind it. And this is more the sensitive mode. So and in this case, it really helped to identify those lymph nodes. So in conclusion, for sentinel node navigation surgery in gastric cancer, it's still regarded as experimental treatment in guidelines, although there's evidence from randomized controlled trials that it can be recommended as an alternative treatment. For esophageal cancer, this is still more experimental and more studies are needed. And ICG-guided lymphadenectomy, there is evidence from a randomized controlled trial that it also improves survival, but probably this has to be also repeated in other studies. And for esophageal cancer, the first reports look promising, but also here more experience and more evidence is needed. Thank you very much for your attention.